It's my great honor to be invited here to give my presentation. I'll share my screen. This is Dr. Yuqing from Beijing Jishuitan Hospital. It's my great honor to be here to present my presentation, OLIF stage surgery in the treatment of multi-level degenerative lumbar stenosis. As we know, patients diagnosed with multi-level degenerative lumbar stenosis is usually old and associated with several comorbidities, and radiographically may be complicated with degenerative coronal and or sagittal malalignment. If this kind of patient treated with standard open procedures to decompress the nerves and correct the deformity, physiological demand on patients and post-operative complications may be high. Some patients cannot tolerate. So in this situation, minimally invasive solutions are necessary for these patients. OLIF is a minimally invasive technique which provides anterior access to the lumbar spine via the lateral retroperitoneal anterior to major psoas muscle. It allows for implantation of a larger cages relatively to compared with transforaminal lumbar interbody fusion, i.e. TLIF, or posterior lumbar interbody fusion, PLIF. It's quite larger cage than the standard PLIF or TLIF. So just by putting in a cage with a large footprint, OLIF has the following therapeutic effects. OLIF can restore native disc height, which stretches and tightens the remaining annular fibers, causes longitudinal destruction of the posterior longitudinal ligament, unbuckling the ligament flavum, and consequently an enlargement of the epidural space and the enlargement of the foraminal area. As preservation of the anterior and the posterior longitudinal ligament and the posterior ligament complex is possible, OLIF standalone can also make the index level more stable without additional instrument. Furthermore, OLIF can also restore segment lordosis and coronal alignment. So in direct decompression can result from lumbar realignment in patients with spondylolisthesis or coronal malalignment. So the OLIF can indirectly compress the neural structures, stabilize the index level, and correct the correction of the malalignment. Since the neural decompression by OLIF is indirect, so during surgery we cannot see the nerve directly. In some cases we cannot guarantee whether the neural decompression is adequate or not. So by literature review, we can see that OLIF can increase foraminal area and height, and increase the central canal area and the diameter by about 25 to 30%. But this meta-analysis shows that current data suggests that ELIF, including OLIF, to be an efficient way of decompression of central canal or lateral efficient way in decompression of foraminal stenosis, but evidence on decompression of central canal or lateral recess stenosis is still low and controversial. So in some situations, such as severely stenotic cases, an adequate decompression directly cannot always be achieved. So a posterior direct decompression may be necessary. Though OLIF standalone can improve segmental lordosis, but it is somewhat limited. With some study, we can see that OLIF standalone can increase the lordosis only by 1 to 4 degrees. But OLIF with low-grade osteotomy, such as, for example, just a grade 2 osteotomy, it can significantly increase the lordosis by 25 to 30 degrees, which is equal to a pedicle subtraction osteotomy, but it is much more minimally invasive. So in some cases with multiple degenerative lumbar stenosis, if treated with OLIF standalone, some question may arise. For example, is indirect decompression adequate, or can associated deformity be corrected satisfactorily? For example, like this case, there are several levels stenosis. So we are not sure whether OLIF alone can decompress all the levels adequately. So in these kind of patients, a staged OLIF with a scaled down posterior surgery might be considered. So I'll show you two cases with staged protocol. The first case is a 75-year-old male who complained of back pain for 20 years. Also radiating pain in both lower limbs for 16 years. In the past 1 year, he complained of severe claudication with walking distance for less than 50 meters. This is the X-ray film of this patient, which shows a very severe degenerative changes in all the lumbar levels, and also a loss of the lordosis. The MRI shows multi-level stenosis. This is the right sagittal view. It shows the stenosis of the right foraminal area of L4-5, L5-S1. Actually, we can also see there is a spondylolysis of L5 here, and grade 1 spondylolisthesis of L5. The mid-sagittal view shows multi-level central canal stenosis from L1 to L5. On the lateral side, we can also see the stenosis of the L5-S1 foramina. This is the transverse view of the lumbar spine. We can see the stenosis at almost all levels from L1 to L5 to L4-5 with various severity. So for this case, the diagnosis is a multi-level degenerative stenosis, spondylolytic spondylolisthesis of L5. So for surgery, we have several options. For standard open surgery, we can choose P-leaf or T-leaf. And for a relatively minimally invasive solution, we can choose MEDICAL. And we also have one-stage OLIF plus posterior instrumentation, staged OLIF plus posterior surgery. I choose the last one, the staged OLIF. For the first stage, I do OLIF from L1 to S1. This is the X-ray taken post the first stage. We can see that all the levels, the disc height of all the levels was restored, and the foraminal height and the area can be, also be restored. Actually, after the first stage surgery, the patient feel very good. The pain in the lower limb almost disappeared completely. After OLIF, we took MRI for the patient. We can see that after OLIF, all the height and the area of the stenotic foramina was restored. There's no stenosis anymore here on the right side. Also on the left side, there is no foraminal stenosis. As for the central canal, we can see that from before OLIF, we can see several stenosis at all the levels. But after OLIF, we can see only a mild stenosis residue at L4-5. So for the second stage, I performed the posterior surgery 1 week later with a selective laminectomy only at L4-5 and put the pedicle screws intramuscularly. So it's a relatively minimally invasive surgery. So with the 2 stages surgery, the patient recovered very well, and he was very satisfied with the outcome. For the second case is a female of 51-year-old. She complained of intermittent back pain for 5 years and pain in both lower limbs for 3 years. And she complained of deteriorating claudication for the past 1 month before the presentation. She is otherwise healthy. On physical examination, you can see that the anterior tibialis, ankle plantar flexor, and the EHL on the right side is decreased. The ODI for the patient is 80. The VAS for back is 8, and the VAS for leg is 5. So the pain is very severe, and the patient is very disabled. Also, the X-ray of the lumbar spine shows a very severely degenerative lumbar spine. We can see a very huge osteophytes, and the shape of the vertebral body also changed a lot, and the loss and the lumbar lordosis was also lost. And this is the CT scan, shows the degenerative change of all the lumbar spine level. The MRI shows multilevel stenosis. Transverse MRI shows multilevel central canal and lateral recess stenosis. For this patient, I also choose the staged surgical plan. For the first stage, I do OLIF from L1 to S1, and the second stage, after the first surgery, I evaluate the patient again, radiologically and clinically, and then to select to do a selective decompression and osteotomy if needed. This is a post X-ray film after OLIF from L1 to S1. We can see that the lumbar spine is still a little bit straight, not with a well lordosis. But the clinical video here shows that this is the video showed before the OLIF surgery. We can see that the patient cannot walk without a spot. He can she could walk only very slowly with some support. At that time, the ODI is 80. But after the anterior surgery with OLIF, the ODI decreased to 48. No leg pain in the lower limbs, and only she felt fatigue in the back after walking for 10 minutes. We took a whole spine X-ray for this patient after first stage surgery. We can see that the PI is 52. The lumbar lordosis is only 12 degrees, though we put 5 kgs. The lordosis was not well restored. The PT is 22 and SVA is 8 centimeters. So there is still sagittal malalignment, which are responsible for the fatigue of the lumbar spine after walking for more than 10 minutes. So for this patient, on the second stage, I do a 3-level PCO from L2 to L5 plus a posterior instrumentation. So this is the X-ray taken after the second stage. We can see that the lumbar lordosis was recovered, restored, and the whole spine X-ray showed that the SVA is only 2 centimeters, and LL is restored to 41 degrees, which is matched with the PI. At this time, after the second stage surgery, the VAS for back is only 3 and leg is 0. ODI is 23, and also the patient is satisfied with the outcome of the surgery. In summary, for patient with multi-level degenerative lumbar stenosis, staged OLIF plus posterior surgery is reasonable and appropriate. After first stage of OLIF, the patient may be re-evaluated clinically and radiographically to determine whether further direct neural decompression or deformity correction are needed. If needed, a selective decompression and low-grade osteotomy can be done. It provides a minimally invasive solution for these kind of complex cases. Thank you. That's all.